Hello, everyone, and welcome to the BackTable podcast, your source for all things endovascular and more. You can find all previous episodes on any platform or our website, BackTable.com. You can also follow us on Twitter, Instagram, or LinkedIn, and keep up with the latest updates and give us feedback through comments. I'm Sabeen Dhand as your host today, and I'd love to welcome Dr. Jay Mathews, Interventional Cardiologist from Bradenton, Florida. Welcome, Jay.
Thanks a lot, Sabeen. Thanks for having me.
Oh, thank you for coming here. I mean, this is actually your first time on our show, and we're going to be talking about these new techniques of using large bore thrombectomy, not on the venous side, but on the arterial side, which is pretty darn neat, and really pushing the innovation. But before we go into that, let's talk a little bit more about yourself. Get our listeners to know you.
Absolutely. I hail from the Northeast. I kind of grew up in Connecticut, Massachusetts area, and went to engineering school in Rensselaer Polytech. I've always been a techie kind of guy, and worked in the startup space, the software world, and then eventually went to medical school and continued to do a lot of engineering consulting all throughout medical school and the residency and whatnot too. And
so you started off before medical school. You did software.
Yeah, I did. I mean, I'm an engineer at heart and a designer, and I spent a lot of time in the human factor space trying to help companies understand how folks interact with technology. And, so I did a lot of stuff with interface design and things like that too. And this kind of just naturally married into the endovascular space evidently for myself, because, everyone focuses on the technology side of things, but rarely do they focus on how do physicians actually interact with technology.
Yeah. No, that's awesome. I love that, because I always tell myself I am techie too, and I never put it on paper and actually did that whole what you have done. So I give you mad respect for doing all that, and you're continuing to do that. So I just like techie stuff at home, I guess. It's really cool. So, and how long have you been now working? Have you always been working in Florida?
No, so I was at WashU for training and fellowship. I did almost 6 years of fellowship there as well too, my residency training as well. So I was in St. Louis for about a decade, and then I came to Florida. I've been in Florida for over a decade now. Yeah.
And how's your practice? If you look yourself online, there's structural, or are you mainly structural? Are you doing or how's your practice broken down?
Yeah, I mean, so obviously I have to remind myself every now and again that I'm actually an interventional cardiologist. And, I think people who follow me online might be confused as to exactly what do I do, because I seem to do a little bit of everything.
Yeah.
But yeah, I mean, well, I'm a technology focused guy. So I love these disease states and how can we do better with these technologies and whatnot too. So I'm probably about 60 to 70% endovascular, and that remaining 30% or so too is a mix between structural and complex coronary interventions as well too. So I still do work in the heart as well too, even though I spend a lot of time outside of it.
That's great. Well, based on your socials, based on your Twitter, you're doing awesome things. I believe you are the one who coined the term lasered cat. Is that correct?
Well, my brother Kumar Madassari and I, we might have some choice words to each other as to who came up with it first, but maybe it was a mutual thing. So, I think, I think even Tim Yates might have even had a hand in it at one point as well too. So we've all kind of, we're not sure who can claim credit per se, but
I love
laser cat is definitely something that we came up with. For those of you that don't know what that is, I mean, it's the concept that a lot of these patients who present with even chronic occlusions within vessels could have hybrid thrombus or soft atheroma, that if you blast your way through that too with atherectomy up front, you're going to end up with trash foot or trash arm or whatever.
Absolutely.
So, if you have easy wire crossing, you can go in there too up front with thrombectomy, clear out that soft core, and then have at it. And in this particular example would be laser atherectomy. It really should be cat laser, right? And laser cat, but the idea was
directing a little bit.
Yeah, I know, but laser cat has a lot more cachet than the cat laser,
When I did it my first time, I actually had to call Kumar. I'm like, wait, so do you do the thrombectomy part first, or do you do the laser part? It's worked great. You guys, that technique is is solid.
But the GIFs, the laser cat GIFs are great. So,
That's the one that
that's why we have to do that.
We will definitely post a laser cat Kumar photo for this. Okay. So now laser cat, we'll move on from that, because actually laser cat, when I've done it, I've used a cat 8 or a cat 6. So large bore, what do you define as large bore? Is that greater than 8 French?
Yeah, it really is. I mean, technically, there are a lot of people out there too. It's actually interesting because I do a lot of work with many different thrombectomy companies. And in fact, I was just in California meeting with some new companies as well too, with new technologies. Everybody's trying to figure out how to do this just slightly differently. But the reality is there does seem to be a lot of reticence in the community when it comes to anything above 7 French. So technically 8 French is considered large bore, but
True.
we're also, especially in the venous space, looking at 12 French, for example, with Indigo Cat 12, but even potentially 16, 20 French, even 24 French if you look at the Inari flow retriever system. But really, they've largely not had arterial applications because people have thought that the size was prohibitive. But what's interesting is that, and this is one thing I think the cardiologists can lay claim to, is that the concept of pre-closure when it came to doing TAVR work and even actually some of our IR and surgical colleagues too, or even our ICs that do EVAR, TVAR work too, have done a lot of large bore closure using proglides or prostyles in a orthogonal position. You could even get away with a single preclose technique, and even closing up to 14 French or more with a single preclose is very viable. So, we shouldn't be scared of large bore when it's appropriate, right? So the idea and the concept behind large bore thrombectomy is that there is just some clot that is so organized and so difficult that just the smaller devices just struggle with them too. And there may be new technologies coming down the pipe that will mitigate some of the organization of that clot that could potentially allow you to get away with smaller form factors. But in the current era too, I've been a big advocate for it. And there are more people doing this now where they're going 8 French and above for arterial thrombectomy when appropriate. And when you have massive clot or overwhelming clot, just extremely organized clot that just will not come through small bore thrombectomy systems. Got it.
Yeah. I mean, bigger is better, right? I mean, that's
I've always said that. I have a slide that literally says bigger is better. I mean, the aspiration force, if you have an aspiration-based system, is an order of magnitude more powerful, both, when you increase the orifice area and also you shorten the
R squared.
Yeah, exactly. So, I mean, absolutely. Go big. Go as big as you possibly can.
And I agree. I mean, I would say in training where I did not do aorta work in my training, I mean, the biggest thing I would probably put in the artery was 7 French. And when I started doing aorta work in practice, like, it was mind blowing that I could throw this 20 French delivery system or sheath into the artery, and you would close it with pre-close. And it's like amazing,
Exactly.
So it's that one, you just have to realize that don't be scared of putting something 10, 12, 16 French in the artery. If you need to do that, that's NBD, no big deal, right?
Exactly.
So tell me let's talk a little bit, like what kind of, are we talking about infrainguinal thrombosis, like SFA pop? Are you going to a Cat 7 or another device? Are you going straight up above that size? Or are we talking about iliacs and aorta?
No, I mean, obviously iliacs and aorta make the most sense when it comes to large bore thrombectomy, but so I do a lot of Lightning 12, and that's Penumbra system too. And the reason why I like using that system is because the tip of the catheter is very atraumatic, very torqueable. Laser cut hypotube allows you to actually navigate into a lot of nifty spaces, and you can go up and over with the system really easily. So, I quickly discovered that you could take this device and take it down into the SFA, take it to the pop. I've even taken it into the tibial vessels.
Wow.
You recognize that the outer diameter of the catheter is really a little over 4 millimeters. So
really,
there are some, patients that have very large tibials where you can actually cork thrombus and actually extract it out. Now, certainly, it's not necessarily your upfront approach, but increasingly I've actually, just gone up with that device. And we've seen this a lot, especially in the COVID thrombosis cases, where we know that the morphology of that clot is just so much more organized. It's different. I mean, you can jump rope with this stuff. I mean, it's really, really super organized. And it just really overwhelms a lot of these other systems that are out there too. But when you were asking the questions, like, what do you do first? For example, I might get access with a 7 French type system and then go in and try with say like a Lightning 7 or something like that first.
Yeah.
And see what happens. But if I see that this is just overwhelming thrombus and I'm not going to make any headway with this, I'll post close in that scenario, because you can
so I was just going to ask you that. I mean, do you go in and you pre-close on your initial access, or
not necessarily? I mean, I always get ultrasound guided access, thinking that I might need to do something like this. Anyway. I think it's a good technique, but ideally identify a spot where you feel closure is going to be good no matter what you end up doing.
So post-close, what's post-close?
A pre-close obviously is, you're going to go up front and first place your ProGlide or ProStyle, and then go ahead and put in your sheath. Post-close is where, let's say, for example, you have a 6 or 7 French sheath in place. Then you just simply, you put up your 035 wire, pull the sheath out, you're holding pressure, and you go in with the ProStyle or ProGlide and go ahead and deploy at least a single,
one
double perclide. Yeah. I mean,
basically just do it that time. Yeah. It
exactly.
works fine.
It's really easy to do. And, the foot plate of the ProGlide or ProStyle is more than adequate to handle a 6, 7 French hole, even an 8 French hole.
Yeah, it's pretty big. I mean, it's important for our listeners to know that you don't burn your bridge by putting a 7 French sheath in, and then now you're like, oh, how do I up to 12, and now I don't know how to close. So you don't burn your bridge with not doing it first. Some people think that, right?
It's interesting. Like, people have done this with, for example, Impellas and whatnot too, that they have to, they put it in emergently and didn't think to pre-close before they put the Impella in. And now what do they do? So there's a whole, dry closure technique and post-closure technique for that too. Yeah. Essentially you put 2 wires in, you put 2 7 or 8 French sheaths in that same hole, and you'll still be able to close it without a problem. And you can do one at a time, leaving your wire in place. That way you don't worry about losing wire access. So I think that's a good technique. And, these arteries are resilient. They tend to snap back down for the most part, and you can close these things without too much difficulty.
Yeah. Now, so the Lightning 12, we've talked about that you have taken it up and over. I mean, I've used, as far as my personal experience, I've done 1 large bore arterial thrombectomy. It was just iliac, ipsilateral, and it worked great. Right. But you said you have no problem taking this 12 French catheter up and over and using it, I mean, all the way to the tibial perineal trunk.
Yeah.
Now, are there other devices you're using as well? Is there other large bore thrombectomy, or what's your kind of algorithm of escalating?
I mean, in the current environment, when it comes to large bore, it's been largely the Lightning system. Now, there are a number of other devices that are on the horizon too that may have a role in this space too for ultra organized thrombus. I mean, Rotarex is one interesting technology as well too. But still, the current device is still fairly small. But the concept that you could potentially kind of do thromboatherectomy is actually very interesting. Very organized clot. So that could be an interesting technology that may have a role in this space as well too. The recent acquisition by Boston Scientific was the Wolf technology from Devoro.
Yes.
And this involves mechanical extraction. And so there is a large bore version of that coming as well too, even up to 18 French. So while that is going to be used more on the venous side as well too, but they have smaller versions. The 14 French one could potentially have applications arterially as well. And the idea is you would actually literally grab the clot, ingest it, and then extract it out of the body. So that presents a lot of interesting ideas. But, right now, what do we have available? I mean, Lightning 12 is a really great option. Atraumatic, trackable, you can use it without a wire. I'll do it typically with a 12 or 14 French dry seal up and over the iliac bifurcation, and then take it down just over a glide wire, advantage wire. I mean, those,
so
those are
lip of the catheter between an 035, 038 wire and the 12, it doesn't get caught. It doesn't, What if you have some plaque there? Do you have problems?
Not typically. And because the tip of the catheter is very atraumatic and it's also angled, right? So typically I use the H torque curve, which has got 2 bends on it. So primary and secondary bend. You've got these wings on the back end of the catheter itself too, and you have this long laser cut hypotube, which allows for good torque transfer. So you simply just rotate the catheter around. You can rotate it over 180-degree bifurcation without having too much difficulty, and you're going to get that 1-to-1 torque, which makes a big difference, I think, if you're trying to navigate around. I mean, I recall a case where, I had both limbs are thrombosed all the way down. It was all embolic yeast, actually. So it was yeast and endocarditis that I went down to the legs. Yeah. So hard as a rock. Really, this stuff is just, the stuff that came out was just, it's not like typical thrombus. But, you're able to rotate that catheter around without using a wire to get into the hypo and then back down the external, and then all the way into the profunda and the SFA, all the way down to the tibial. So again, that was all done without a wire. And I think amazing. The key is if you got PAD, of course that makes it a little bit more challenging. And what I would encourage people to do in that kind of scenario, if you do worry about the lip of the catheter itself to interacting with plaque, is that you may have to do a telescoping technique, and you can simply insert a balloon to the lumen of the catheter and then just kind of balloon assisted tracking.
Yeah. Just daughter it through kind of.
Yeah, absolutely.
That's great. And I mean, again, I think it's a hard concept to swallow, but it's atraumatic. I mean, you can push that 12 French. In veins we do, we push things, and but arteries we get a little bit, timid. But this thing is atraumatic, and you're pushing it without a wire sometimes. So that's awesome.
Right, absolutely. I mean, the reality is this: if you have significant PAD, most likely the thrombus that's occlusive is going to end up anchoring itself right at that location anyway.
Yeah, so
most of the time you don't really have to go through that to get the rest of the clot that's there. But if you do, then, you can certainly treat that and then proceed on downstream from there and address, things as needed afterwards on the way out.
Yeah. No, that's great. That's great. And then, I mean, is there a role for you mentioned 14 French of the Wolf system. Is there a role for bigger? I mean, you think 12 French, is 12 a good number pretty much to take care of anything renals and below in the arterial bed?
I think so. Obviously these companies will continue to come out with bigger devices. And so it remains to be seen, right? So, there is probably a point of diminishing returns where you sometimes will get almost so big that then does it become cumbersome to navigate these devices? So it's a balancing act, right?
Yep.
And it's also polymer science and materials engineering. When you get these big giant devices in place, they lose their flexibility and some of the features that you like. So there is a sweet spot there, right? So the 12 is a very soft, atraumatic, flexible catheter. It remains to be seen whether or not larger catheters will continue to perform like that too. I mean, it becomes very expensive and technologically intensive to really have an ultra trackable, flexible, catheter that does everything that you want it to do in a large form factor, right? So we'll see.
And then just put a neuro tag on it, and then it's
exactly,
10 times more, right?
Right, exactly.
Question for you. So let's go on technique a little bit. Are you putting the catheter, whether it's large or normal, 7, 8 French, are you taking it to the face of the clot and then just aspirating and then sitting there? Are you pushing while it's aspirating? We have a lot of different techniques we use in neuro.
Right.
And what is your technique? And then I want to know some adjunctive techniques too.
Yeah, so absolutely. So, the adapt technique that you were describing, was largely, adapted for the extract technique,
nice.
The prism, into the, from the prism registry and whatnot too.
Yeah.
So, Jim Beninati talks about this quite a bit too, essentially what they developed, the idea that you come onto the face of the thrombus, sit on it for 90 seconds, and then allow that clot to digest into the catheter. And doing so allows you to really get good purchase, especially with a large bore system. I mean, the thing about it is that, with the larger systems, especially with more mobile thrombus, it obliterates the clot. So it's not like, I mean, most of the stuff that you would, spend a lot of time taking several passes at with a smaller system, with something like a 12 French system, you're going to just obliterate that thrombus. And the only stuff that you're going to have to spend a little time on is the stuff that's so organized that it's not going to really come through any of the other systems. So that type of thrombus, I have another example I can think of was a patient who presented with blast crisis and essentially embolized all of this, cancer material down his legs. It was the clot that was formed, which was when we sent it off to path, it was all blast, was indistinguishable from tendon or bone. I mean, it was that hard.
Wow.
So you can't suck that out with even the 8 French system. And, it plugged up the Cat 12 and even the dry seal sheet. I mean, the dry seal was
corked it in there.
Corked in the dry seal. And I had to aspirate out the dry seal on the way out. That type of stuff, when you look at it, it looked like I'd done an endarterectomy.
Yeah. You're like, so is this artery? Or
well, right, exactly. I've had people look at this and ask, what was this?
Yeah.
So, that type of stuff. I mean, I think the extract technique is really good for corking out discrete type thrombus. Now, if you have overwhelming clot, that's when we use, separators and whatnot.
I was going to ask about that.
Do you use a separator? Yeah.
Do you use
I used to not use it because I believed in the extract exclusively for many years.
Yeah.
And then I discovered that I was like, why am I spending all this time struggling? Especially when you use a smaller system. I think the separator is really key to break this thrombus down into smaller, more manageable chunks without corking or clogging up the system. So the corking technique is good, but the problem is you have to go in and out multiple times, and sometimes that gets to be cumbersome.
Yeah.
So utilizing the separator, especially when you have more organized clot, is a good idea. Now, there are other devices out there too. People have utilized, a lot of the stentriver type technology in conjunction with these types of catheters with variable degrees of success. The problem with some of those devices is that they're so soft and they're designed to be used in the brain.
Yep.
Largely, they end up collapsing down or not really doing as much, I think, in the lower extremities. But people have done endofogarty. They've taken a balloon and essentially inflated that to low atmospheres and just kind of pulled back into the aspiration catheter. That's a very valid technique as well, too, and can be done through the lumen of the 12 French catheter, even the smaller ones as well, too. So I think those types of adjunctive tools and techniques can be useful.
Using a filter? Ever used a filter?
Yeah, I've used a filter several times, in fact. And I think there are a number of devices coming down the pipe that will utilize a filter-like stentriver technology with aspiration. The only drawback with using a filter I've encountered, I had this in a couple upper extremity cases too, was that sometimes you overwhelm the filter and the filter spills over and then you end up sending stuff downstream.
Yeah.
So that's where I think coupling it with aspiration is really key to make sure that whatever you have in that basket doesn't spread out. But you do risk squeegeeing that clot out of the basket and going downstream, and then you're going to chase after that clot.
Yeah. Do you have any issues with if you do use the separator at the tail end of the clot, at the distal end of the clot, does it embolize or no? If you're,
if you're
pushing that,
aspirating, it's less likely to do that, but it is possible if you have a very organized thrombus to push that clot downstream. But I think that's why it's key to only utilize a separator while you're under aspiration, rather than try to, some people will use it to kind of almost guide their device down, and, they're kind of sailing on down with the separator leading in front of the catheter. Yeah. I think that technique is a little bit problematic. I think you have to be careful with that too.
You're pushing
it's got a polymer jacketed bead on the end of it too. I mean, it's not small by any means, and that can push stuff downstream. I mean, it's not like taking your wire down, which should be able to hopefully glide its way around that clot or organize stuff. Yeah.
So, I mean, we are talking about all this thrombectomy. Is there a role for lysis? Are you doing lysis, or you have managed to avoid it?
My life's goal is to find a way to eliminate thrombolytics entirely. And I just go back to over a decade ago, when I was doing this, and that's all we were doing. We were just doing CDT on everything. And I mean, I remember patients having strokes, bleeding systemically and all these other types of things. And even when we reduced their thrombolytic burden, it still wasn't always benign. active site bleeding. Every patient, you knew that the TPA was working once they started getting a hematoma in their joint.
Totally.
Right. So, I mean, the reality is, do I still use local lytics once in a while? Absolutely. I use it very sparingly and selectively, but I've largely found that these techniques, especially even with the large bore techniques that I'm using, I've been able to really reduce the need for thrombolytics. And the only time I really use thrombolytics at this point is if I've got a situation, let's say, for example, on a lower extremity where I'm just still not happy with the distal microvasculature.
So you're doing it for
little
that.
plugging there too, in which case then I might do 6 or 12 hours of TPA just to kind of help address that residual clot burden downstream. Let me tell you that, I mean, even into the pedal loop, the arch itself, I'll take the Catheter X catheter down there too without difficulty and aspirate a lot of that stuff out. It's really, we're talking the microvasculature where it just, there's a point where how long do you want to continue to prolong the procedure versus, you have to weigh the risks and the benefits. I mean, there are just some patients that can't get TPA. And I think there are some that it's okay.
Yeah. So, someone who they present to you with, SFA pop, tibial thrombosis in the acute setting, how long of a case is it for you to, perform that same day thrombectomy?
Yeah.
There's an argument for lysis where you just drop in a lysis catheter and 10 minutes later, the patient's upstairs. But how long does a thrombectomy take?
So let me answer that first question about the argument for the lysis, because I still see a lot of people doing that because it's the most expeditious thing to do, but it's not necessarily the right thing to do for the patient. Why is that? Because that patient is still ischemic during the entire duration of therapy. So you're going to see a lot more ongoing ischemic issues, more dysfunction, and more reperfusion syndrome because they have delayed reperfusion. And then ultimately they end up, you see more compartment syndrome and fasciotomies being done in those kind of patients. At the very least, if you're going to end up using thrombolytics, establish some flow. So establish a channel through there so that some blood is getting down to the lower extremities. And then, honestly, the TPA will work even better in that kind of scenario. Rather than just having TPA dripping into a dead-ended vessel where it's not going anywhere, that patient could have required, 1, 2, even 3 days of lysis in order to get a good result. And I'm a big evangelist when it comes to telling people, if you are a TPA type person, at least try to get some flow with some device, whatever it may be, before you try to drop a lysis cap. Now, with regards to doing thrombectomy, and, this is where some of the smaller bore technologies have actually been quite nice. I mean, for example, the Lightning 7, I use that both above and below the knee now in the same setting without switching out devices, like where you might have used before a Cat 8 and a Cat 6. I just use the Lightning 7 in one setting. It's best of both worlds, right? So you've got a catheter that essentially has the aspiration force of almost an Abbey 8 French catheter in a form factor that's quite small, and then is easily taken through the tibial vessels without a lot of difficulty. So, that case takes me about an hour. I mean, my goal is to do these thrombectomy cases within an hour. And, or less.
That's great.
I mean, some of these cases I'm doing in 15, 20 minutes, and that's great. Right.
Yeah.
And, that's a lot better than where I was at when I first started doing this. And, the staff fatigue issues, we've got a lot of cases going on. We have the pandemic going on. We really can't rely upon lysis because we don't have a place to put these patients who are needing thrombolytic infusion. They're going to stay in our cath lab holding area. There's not an ICU bed for them to go to. So, we want to try to get this done, but we can't also have a situation where the staff are just sitting around with these patients for hours, trying to manage them, when we can do an on-table solution relatively quickly and get everybody home.
Totally. No, that's great. Yeah. I mean, you made a good point about, establishing flow to the foot and getting that there. And it's amazing that you can do some of these big cases, in less than an hour. And it's a remarkable effort for the patient too. So is there anything that you can discuss about, that's in the future for this? Anything we can look forward to for thrombectomy arterial that you're allowed to discuss?
there's a lot more that I'm not allowed to discuss than there is that I can discuss. But, we can talk about pie in the sky type stuff too, because I spent a lot of time with companies who are early, entering the space. We're even kind of describing wish lists of what's out there as well too, for what people want to do. So, I think some of the new avenues of research are looking at what makes clot really.
Okay.
What's acute clot, subacute clot, chronic thrombus? How do you differentiate between the types? You can't really tell by an angiogram.
Yeah.
And so could you potentially tell more about thrombus morphology and how to address it based off of some type of technology? Could you use different types of fragmentation? Is there, we've talked about maceration devices, extraction devices.
Yep.
Is there a way to fragment thrombus? There's a lot of different devices out there too that have been used historically, like acoustic pulse therapy with ecos and whatnot too. But could you deliver ultrasonic energy in different ways? There's a few companies looking at those kind of applications. Whether or not that even works in thrombus, it's kind of unclear. I think that there are also companies looking at ways to utilize nanoparticles as well too. So this is kind of a fascinating space where utilizing nanoparticles with different types of either thrombolytics or other non-biologic agents that would fragment thrombus as well too. Which that to me seems so exciting.
That's crazy. I can't wait.
It sounds so science fiction that it's it's craziness. Magnetic nanoparticles. That's
nanobots.
Area. Exactly. And you can imagine you could really pulverize thrombus that way too, potentially with external devices. I think that's fascinating to me. So I think that there's a lot of stuff coming, and I think there are plenty of big players that are still looking for solutions to add to their bag. Honestly, the whole aspiration catheter thing has been done. And I think that, everyone can have a Me Too type device out there, but I think really creating differentiating technologies is what is going to separate out, the technology moving forward. I think people want to have devices that make it easier to remove clot. That's one of the reasons why I've been promoting this large bore technique, because it makes the case more efficient rather than spending 2-3 hours in there too, or even saying, bailing out and saying, forget it, let's just do open. Okay. I a lot of these cases, even some of these R2B cases that typically, historically speaking, were surgical only, can be addressed with endovascular techniques in an efficient manner. And if you have got clot that goes from the aorta all the way down to the, to the calf, that's a multi-level open procedure. That's not
easy. Yeah.
And if you could do it with a single access or even just two spots with, percutaneous closure, that's a big deal. I think that reduces the morbidity of these patients.
Yeah. No, that's awesome. Yeah. It's awesome what you're doing. I'm really glad to have you today. The stuff that you post online and all of this, it's great, and literally I hope our listeners are more comfortable using these larger bore devices, in the arteries and not just the veins. I think, keep doing what you're doing, Jay. It's really nice to have you. Any parting words of wisdom for our listeners?
Yeah, a couple of things. One is just suck it. Number two, go big or go home. Right. So
that's great. No, it was really awesome having you here, Jay. Thank you so much. We'll look forward to doing some more topics with you, and literally we can't wait to see what's on the horizon, all the cool stuff that you're coming out with your technology background. It's super exciting to see what's out there.
I appreciate it, Sabeen. Thanks so much for having me. It's been great.
Yeah, of course. Thank you.
Thank you.
Nice, Jay.